Hello and welcome to today's webinar, When Should I Perform Point-of-Care Fluorescence Imaging of Wound Bioburden? Guidelines based on Delphi Consensus, sponsored by MolecuLight. My name is Miranda Henry, the Editorial Director of Wound Source, and I will be the moderator for this webinar. Today's program will discuss the guidelines for using fluorescence imaging for bacterial detection as created by Delphi Consensus. Presentation will be followed by a question and answer segment with our panelists, so we encourage you to submit your questions to us throughout the program. Before we get started, I want to run through a few brief details with everyone viewing today's webinar. At the bottom of your console are applications you can use during the webinar. To submit a question to our panelists, please select the Q&A app icon on your screen and type your question in the field provided and select Submit. We'll try to get to all of your questions during the question and answer period. Questions are related to MolecuLight products and educational offerings that are not answered today. A MolecuLight representative will follow up with you after the webinar. You can expand your slide area by clicking on the Maximize icon on the top right of the slide view, or by dragging the bottom right corner of the slide area. We have included additional information on today's topic. On the right of your console, you will find a list of resources available for download. You may also access this information by selecting the document icon in the bottom tray of your console. If you have any technical difficulty during the webinar, please click on the Help app, which is the application with the question mark. This webinar is being recorded and will be made available on demand. If you have any other requests pertaining to this webinar, please contact our sponsor using the Contact Us app located in the tray of your console, which is the application with the email icon. As a brief reminder, HMP Global does not give medical or reimbursement advice, nor do we provide medical or diagnostic services. The content of today's webinar is for informational purposes only. The views and opinions expressed in this webinar and contents are solely those of the presenters and do not reflect the views of Wound Source, HMP Global, its affiliates, or subsidiary companies. Please also note that while MolecuLight is providing a platform for this discussion, it is not responsible for the content or the opinions expressed by the speakers, nor is the U.S. Army. The information included in this presentation is provided for general information only and does not constitute professional advice. The content described in this presentation is intended for global audiences and as such may not reflect U.S. claims for MolecuLight. Now, at this point, I want to welcome and introduce our panelists for today, Dr. Alicia Rapallo, Martha Kelso, Jennifer Hurlow, Dr. Charles Anderson, and the leader of this Delphi study, Dr. Thomas Serena. To learn more about our speakers for today, please select and expand the Bio app. Thank you all for joining us this morning. Now, to get the discussion started, the panelists will first describe the current challenges surrounding wound bioburden and infection.
On this slide, we're talking about what are the current challenges surrounding wound and bioburden infection, prevalence of bacteria and biofilm. What the MolecuLight device has been able to demonstrate is that it will pick up greater, equal 10 to the 4th bacteria or greater with the scan. We now know that that is a level that starts to impede healing. So the ability to pick that up with the device becomes very, very important.
Mm-hmm. We know patients with multiple comorbidities often have challenges mounting those detectable symptoms of infection. And we've seen even in our practice in the long-term care arena, we're treating them on Tuesday, and on Thursday they've sent them out to the emergency room for symptoms of sepsis, which tells us that we missed those signs, we missed the infection when we were there 2 days prior. So as a result, we tend to be overly cautious. We liberally prescribe treatments, antibiotics, antimicrobials, sometimes unnecessarily. We don't want to get sued over sepsis and death because we missed those symptoms in the wound.
The importance of being able at point of care to pick up 10 to the 4th bacteria or greater allows us to then take a very proactive approach to wound care versus the reactive approach where we wait for clinical signs or symptoms or we wait for the results of a culture. So we can be much more timely and appropriate in the early care and with that can prevent progression of that bacterial growth.
Also related to polypharmacy and antibiotic abuse, antibiotics are really the only pharmaceutical category that loses efficacy with repeated use. And it has been found that in wound care, the 3 top reasons that wound providers prescribe antibiotics is number 1, clinician fear of bad outcome, number 2, patient demands, and number 3, uncertainty about whether antibiotics are needed. Clearly, these are not good reasons for prescribing an antibiotic.
You're completely correct. If I might jump in, you know, that leads us to reactive versus proactive care. Are we just reacting to the wounds themselves? And do we really understand what the wound has, what the peri-wound involves? And are we really treating and managing it properly or appropriately, rather than waiting for the patient to come back and see that if our treatment actually worked or not? So that kind of leads me to how to assess treatment efficacy, right? Sometimes we don't know, you know, we don't see a patient in a week or 2, and it could, you know, get worse or better. So it's important to know whether the treatments we have selected, you know, are actually effective beforehand.
Yes, and also as somebody who wants to follow evidence-based wound care, there are so many guidelines. There's IWII, there's AAWC, there's IWGDF, there's IDSA, there's so many guidelines, and sometimes they conflict. Sometimes they recommend different types of treatments, so I get confused, which do I follow?
Many of you have probably already know or have seen MolecuLight. It is a device that shines a light, a violet light on the wound at about 405 nanometers. When you shine that on the wound, the bacteria or the porphyrins or pyrividines in Pseudomonas, they'll shake. And when they shake, they emit their own light. The device picks up that image that the bacteria put out. So you get red or cyan fluorescence. So the red fluorescence is most bacteria. You can see that in the picture. And then on the bottom is Pseudomonas, which has this cyan sort of white halo appearance. And once you've seen it a few times, it's pretty easy to pick up the fluorescence. This group got together and decided that we really need to do guidelines. So we have this fantastic new device that can detect bacteria greater than 10 to the 4th. That's the level of bacteria that interferes with wound healing. But how do we use it? We came up with a number of questions that we put through a Delphi Consensus process. And I have to tell you, I've done a lot of Delphis, and I've never had one go this well. It may be the panelists and the authors that are here on it, I would certainly attribute it to that. But we reached greater than 90% consensus on just about every question that we went on. And that's just, you know, really was an amazing agreement among folks using MolecuLight device to detect bacteria. So the study design and demographics, you can see there were physicians, podiatry, nurse practitioners, WOCN nurses, really physical therapists, really a nice spread of the multidisciplinary team that does wound care. We had mostly US-based clinicians. And most of them were very experienced in wound care. You can see that the majority had more than 20 years. And site of service, and this is really interesting. We chose site of service that wasn't just the hospital outpatient wound care department, because this type of technology, detecting bacteria, is important no matter where you are. So whether it's a hospital outpatient or inpatient, private office, skilled nursing facility, all of these are very important in using and detecting bacteria. The key topics: clinical workflow, when to use it, the frequency of imaging, and the report and the impact of that on the outcomes. How do you incorporate fluorescence imaging into your clinical workflow?
So we have the ability now to scan and pick up, as Tom has indicated, greater than 10 to the fourth bacteria. The question becomes, now that we have that ability, who do we scan and what do we do with that information? So part of the consensus document, we had a 93.5% consensus looking at this flow diagram. Critical part of the paper, and I think a critical part of this presentation, is now that we have that ability, what do we do with that information? We've incorporated this into our workflow, and as part of the paper, there's a criteria now for who obtains the scan. And then once we get the information, we decide how we're going to appropriately use that information. As we go through the rest of this presentation, we'll break down this slide and go every component of how we use that information.
Here's an example of how I used imaging, procedure to evaluate the efficacy of cleaning. And, the image that you see on the left, you can appreciate it's not impressive clinically, but you can see next to that, before cleaning, the fluorescence image demonstrates this red. So the image shows fluorescence from bacteria, either red or sign-in signals. And if the tissue, is green, then if the tissue appears green, then it's just tissue itself. But here we can see the decrease in red fluorescence after a 30-second scrub with a commercial cleanser. So with this information, I can really target my care and treatment of wounds.
Which we can also, images can be captured before, during, and after debridement. I know you do a lot of this, Dr. Anderson. Would you want to comment on this section?
Absolutely. So that's probably one of the more common indications in our clinic is a chronic wound that is failing to progress. So we scanning, I think it's very important to point out that the scanning is not a substitute for clinical assessment. So when we see that patient in the clinic, we still do our intake. We do a history and physical. We do a clinical assessment, and then we move on with the scan, which is indicated will pick up greater than 10 to the fourth bacteria. With a positive scan, that gives us an indication of the area that we want to focus our debridement. So in addition to a general debridement, if we see fluorescence in that image, then we would focus on debriding that fluorescence. Once that debridement is complete, then we would rescan to make sure that we've removed the bacteria with our debridement. I think we have a video here that is going to demonstrate that. Here we are scanning a wound. At the same time, what you'll see is I'm debriding that wound. Many times we will actually do the image at the time we're debriding. Here you see the fluorescence around that wound. And now with the curette, I'm debriding and trying to remove that fluorescence, that tissue that obviously has bacterial burden in that tissue. And then at the completion of that, we would continue to fluoresce to make sure that that bacterial burden has been removed. Of interest, patients become very, very involved with the scanning. They now understand why we're debriding. We can share the scan with them. And I truly believe that one of the side benefits of the MolecuLight scanning is to help educate patients and actually help with compliance. They understand why we're doing things, they can see the progression, and that then allows the patients to have a more active role in their care.
That's a terrific video, Chuck. Did I see you using it in video mode as well?
We do at times, and it's something that is very easy to do, and we can actually watch the results of the debridement as we're doing it.
What if fluorescent signals from bacteria persist? Jenny, you have some experience with this.
Yes, thank you. This is a diabetic foot ulcer on a patient with neuropathy, but easily palpated pedal pulses. No dialysis. The patient is neuropathic and moderately impaired glucose control. To me, one of the most valuable aspects of the MolecuLight workflow is the information that we can pick up on the next steps. As you can see, after initially debriding, I took a picture and found more red glow after I debrided, which indicated to me that I needed to use a topical antiseptic dressing. However, in the original picture, you can see there are no signs of acute infection. So I didn't culture and I didn't start antibiotics. I simply ordered a topical antiseptic dressing and then asked the patient to come back in a week for reevaluation.
Just an additional comment. This is Chuck Anderson. Additional comment on that. And not only does it help us decide what dressing we're going to use, whether or not we need an antibacterial dressing, but oftentimes that information can tell us what we don't want to do. So, for example, if we have persistent bacteria, we would not put on a biologic tissue at that point in time. We would continue treatment until we had a wound that didn't fluoresce, and then that would be the setting where we would move ahead with more advanced therapies.
Absolutely.
What if the fluorescent signals are no longer present? This dovetails very nicely into Chuck's comment there. Alicia?
I agree with you all. I mean, I'm in line with Dr. Anderson and Jenny and yourself. Just as it's important to have a signal, it's also important not to have a signal. And you can see on the left-hand side the fluorescent image before cleaning, and then after the cleaning. You know, it's very important for me to determine that we don't have a signal when we apply a cellular tissue-based product. So the absence of red fluorescence enhances my confidence that a cellular tissue-based product is ready to be placed.
Now, do you think this is going to have change the outcomes with these advanced therapies?
Definitely. You know, not only just advanced therapies, but the way we manage and treat patients.
What wound types can I perform fluorescence imaging on? What wound types are there? Pretty much everybody that walks in the door: diabetics, postoperative wounds, surgical site infection, venous leg ulcer, pressure ulcers or injury, and traumatic wounds. And this corresponds very well with the large clinical trial that demonstrated the efficacy of the MolecuLight device with so-called FLAG trial. But it was also a real-world trial. In other words, the inclusion-exclusion criteria were very broad. And so we did imaging and biopsies of all wound types and basically patients that walk through the door. Next, we want to talk about what are the clinical indications for imaging. And let's start with history and comorbidities.
With the Delphi approach, we had 100% consensus among the expert panel. And getting 100% consensus for the wound clinicians that participated in the study to agree is remarkable. It's practically unheard of. And so those things that we all agreed on were things like history of delayed wound healing. So if a wound hasn't healed at, greater than the 4-week mark, the chance of it not healing due to bioburden or infection is great. So those are wounds that we would want to consider for MolecuLight or bacterial fluorescence. Obviously, history of wound infection. If you've had a history of infection, your chance of having a wound infection in the future is elevated or great. Failure of previous treatment. We're doing the right things. We're using, good practices for wound healing, and it's failing those treatments, even using advanced modalities. We don't want to spend a lot of money on advanced modalities if they're not going to work. It adds burden to our healthcare dollars. It's frustrating for the patient. It's frustrating for the clinician. The positive clinical signs and symptoms of infection, if there's erythema around the wound, peri-wound that's spreading, if there's increased friability, pain, any of those clinical signs and symptoms, we want to take out our MolecuLight and see if there is 10 to the 4th power of bacteria or bacterial burden in the wound. And then the comorbid medical conditions that we've talked about so much. Obviously, comorbid medical conditions can mask clinical signs and symptoms of infection, particularly people with diabetes, autoimmune disorders, immunosuppressant, obviously on chemotherapy agents, and the elderly. Certain medications can suppress our immune system as well. And anybody that has multiple comorbid medical conditions that elevates their risk to loss of life or loss of limb, particularly if they've had sepsis before, these are things that the expert panel felt was important to include as one of the clinical indications or medical necessity for MolecuLight and bacterial fluorescence.
It's pretty rare to get 100% consensus with a group of experts. In fact, this may be the only time in a Delphi I ever saw it. Martha, maybe you can talk about this particular patient.
Sure, thank you so much. This is one of the patients that we treat in long-term care. We like to refer to them as residents. And they did have a reduced autoimmune function because they were diabetic. They also had poor blood flow to the lower extremity. This is actually on the posterior side of a heel. The wound itself, the peri-wound, doesn't look that bad. It almost looks like there's eschar in place, but we don't have purulent drainage coming out. And so this is one of those wounds that doesn't really meet the clinical signs and symptoms of infection. And yet, when we used MolecuLight or bacterial fluorescence, look at that red glow. So it changed the outcome in the treatment. Instead of continuing with dressing changes, the advanced wound clinician decided to sharp debride, try to get that unhealthy tissue out of the wound and clear the bacteria from the wound. So we use these images to overcome the uncertainty of clinical signs and symptoms of infection that simply may not exist because of the other comorbid medical conditions and the patient's current status. So we want to be able to detect those clinical signs and symptoms to thwart off infection, sepsis, death, ER visits, the list goes on and on.
Another feature of the MolecuLight device is that it can measure the wounds. And Chuck, are you using the device to measure wounds?
We are. So this next slide, I think, is a very important slide and shows the capabilities of the device. First of all, you're able to capture a regular image so that that can go in your medical record. One of the features of the device that we use, I know everybody that has the device doesn't, but we find it very, very useful, is once we scan a patient, we start a patient file. And so it's a number, so number 564 or whatever, and then every time we scan that patient, image goes back and the scan goes back in that file. So it's very easy once we pick up the device to go through that and see the sequence. So you're able to capture an image, and then you're able to use the device to actually do measurements and document the measurements of the wound. In this particular series of pictures on this slide, when you look at that picture, this is a wound that had a history. So I'm part of a limb preservation clinic that had a history of delayed healing, just wasn't healing. So when you see the last picture on that slide, you see there's significant fluorescence. Many times, as was the case here, when you debride the callus, you actually see more fluorescence under that callus. So here you see fluorescence not only in the base of the wound, but you see fluorescence around that wound. We would start with an antibacterial dressing, but many times where the fluorescence actually extends out in an irregular pattern outside of the wound, we will also add systemic antibiotics. So it gives you a lot of information on why this wound had delayed healing.
Most patients don't mount clinical signs and symptoms, and pretty much everyone agreed that if you had one of these symptoms, at least, that you would warrant the use of fluorescence imaging. That includes, obviously, the cellulitis or lymphangitis, delayed wound healing, the wound's breaking down, smells, really bad, local warmth or increase in temperature, increasing pain, particularly jumps more than 2 points on the 10-point scale. Crepitus, if it's granulation tissue, very viable. And we were able to get a lot of consensus on if you had any of these, we see this, then you should image the patient. That was a nice consensus, although, again, I keep in mind that the clinical signs and symptoms, as we saw in the FLAG clinical trial, may not be present, yet bacteria may be in the wound at a level will impede wound healing. What about a history of wound infection? Jenny, you've done a lot of work in this area.
Thank you very much. This is a picture of the earlier diabetic foot ulcer that I talked about. This is 1 week later. The fluorescent imaging confirms for me that the plan of care was appropriate. There is less red glow in the wound, so the topical antiseptic was an appropriate choice. And the fact that I didn't use antibiotics also, it's clear that it has gotten better without antibiotics, which is critical these days. Interestingly, though, the fluorescent picture, if you look up at the first web space, the fluorescent picture picked up a large bacterial load in that first web space that I didn't, unfortunately, notice without the fluorescent picture. Then closer evaluation showed an area of maceration and a wound. I would not have noticed that because clinically there were no signs of acute infection. It was simply maceration, no drainage. But the MolecuLight helped me to really prevent a new problem.
Just a comment on that. Again, I work in a limb preservation clinic, and when we're focused on a wound, after we have, just like you said, after we have scanned that wound, we will just take that scanner and scan both feet. And it's amazing what you see. We look between the toes, and oftentimes we will see a fissure that you don't recognize clinically. A little silver alginate between those toes. Maybe you've prevented something. The other interesting thing is many times we'll have a patient present with a diabetic foot infection with no obvious wound as a source. Sometimes taking the MolecuLight and looking between the toes, you'll find the source. You'll find a fissure with significant fluorescence, which probably was the entry point for that diabetic foot infection.
Interesting.
The next was for clinical indications was procedures or treatments, and again, really high level of consensus. Everyone agreed that on the use of imaging before, during, or after the following treatment procedures. If you have a positive image, you should follow up. I think we've seen that from the panelists and the cases that have been presented. Prior to or following debridement, and we saw that video. We saw Jenny's slide with after you do debridement, you may or may not have removed all the bacteria. It helps you in your treatment decision making. If you're suspected or confirmed a biofilm, or if you're following up on having written an antibiotic prescription or antimicrobial for that matter, and then prior to and then follow up on a cellular and tissue-based product, and then prior to other therapies or concurrent with other advanced therapies such as negative pressure wound therapy.
I agree with Dr. Anderson And Jenny, I always scan my patients now since I've had the MolecuLight device. And you can see here, this patient on the left, you can appreciate that this patient's had several cellular tissue-based products. And then when I saw the patient, I actually scanned the patient. You can see to the right, and you can see this bright fluorescence green white color. That's the cyan, and that's indicative at the edges of the wound of Pseudomonas aeruginosa. So this is a great example of the cyan color, but as it appears on the fluorescent images, and this is what you don't want to see when you have a patient that you want to put a cellular tissue-based product on. So that kind of, I knew at that point just to hold off on that application.
Are you doing that routinely now? Is that a routine part of your practice when you're before doing these advanced therapy products like CTPs?
Absolutely, Tom. We do this routinely now on all the patients that we're thinking about placing an advanced therapy on.
On that same vein, this is a negative pressure wound therapy, and one thing we have noticed is that the sponge dressings in negative pressure wound therapy will collect bacteria as well. And we've just completed a clinical trial demonstrating that that you can clear that bacteria with a variety of different antiseptics. And when you do that, you can also accelerate wound healing. So it's a very important device to be used in conjunction with advanced modalities, as Elise just mentioned, using it with before and during CTP use, and then with negative pressure wound therapy. So again, a fairly high level of consensus. I have to say, this is a little lower than the 90s. Now, for Delphi, remember, they're 70% and above. That's great. So a little lower than the 90s we're getting used to. However, you know, a lot of us, having used the MolecuLight device for some time, find that our sampling is decreasing. But just to go over what the agreement was, to follow up on a positive microbiology testing or culture, inform and need for the location of where do I sample, and inform referral for microbiological analysis.
One of the questions that was proposed to our Delphi panelist members was how often they could perform fluorescent imaging. And 93.5% of the time, the expert panelist concurred that they should perform it in the following manners. So fluorescent imaging could be performed on wounds at baseline. We want to know what we're dealing with when we see the wound the first time. So for sure at baseline, but also during the first 4 weeks, or if there's an increase in wound size observed. These are all things that we would worry about or suspect that there may be bacteria present, even if there's not clinical signs and symptoms of infection. Fluorescent imaging can also be performed on a weekly basis, especially for patients that meet criteria for imaging, such as clinical signs and symptoms of infection. And if a wound is positive for fluorescence, we would want to do fluorescence imaging performed no more than on a weekly basis, unless it's otherwise medically indicated. So obviously, if they're coming back in with a foul, purulent smell that they didn't have previously, and you just saw them on Tuesday, now they're back on Friday with a concern, that would warrant additional imaging or fluorescence to determine if bacteria is present. It's one of the most common questions that were asked for users of MolecuLight, and we were able to answer that question through the Delphi Consensus.
On this slide, how often can I perform fluorescent imaging? The image on the left, when you look at that wound, there's macerated skin, but not an impressive wound from the standpoint of clinical assessment. With the first scan, what you see is a little rim of fluorescence. However, once that macerated skin is removed, you see a significant amount of fluorescence in the wound and around that wound. That helps you decide, number one, how you're going to treat that wound. With that degree of fluorescence, you're going to make sure you're using an antibacterial type of a dressing, but it also helps you decide how often that patient should come back for the next assessment and additional debridement if required. So how often can I perform imaging. Generally, we don't do it more often than once a week, but the information that you obtain from the scan can guide you as to how often that patient is going to return to the clinic and how often you're going to repeat that scan.
So going over a summary of the recommendations thus far, one is everyone agreed that training is needed to effectively perform fluorescence imaging. The clinical workflow for fluorescence imaging complements standard assessment and treatment. As part, as Chuck mentioned earlier, it's part of an addition to your physical examination. We mentioned that the medical history and comorbidities in the presence of clinical signs of infection will help us in deciding when to use fluorescence imaging, such as the wound's not healing very well. Fluorescence imaging may be performed prior to, concurrent with, or following many common procedures and therapies in wound care, particularly, as we mentioned, advanced wound care, such as cellular and tissue-based products. And fluorescence imaging should be performed no more than weekly unless there's a special circumstance. So looking at the impact of fluorescence imaging on treatment planning, we see that how often does it change your plan of care? It's fairly frequent. So and I'll just open this up to the panel for their comments on this.
When you look at the information that you obtain, not only does it help you decide, as we've talked about, what to do, the type of dressing to use, how often to have that patient come back for reassessment, whether or not you need to add antibiotics, but oftentimes can help you decide what you're not going to do, including placing of a biologic. Somewhere around 60% of the time, if you just make the decision what you're going to do on that clinical assessment alone, and then you do the scan, about 60% of the time something's going to change.
Our clinicians are obviously performing MolecuLight pre-debridement, and then once they feel that they've cleared the areas that are highlighting and areas of unviable tissue, they're fluorescing again. And what's happening is we can see that we've removed the bacteria from the wound bed. So it's reduced our need to do tissue cultures or tissue sampling by more than 80%, to the point that our PCR lab company called and asked if we had fired them. I think they had only contributed 6 samples in multiple states, and so the PCR company was calling to find out if they had done something wrong, when in fact we just didn't need to be doing tissue cultures anymore. And in turn, it's also reduced our antibiotic usage in the elderly, which is huge. It's huge to not have to prescribe and contribute to the polypharmacy issue that we often see in the long-term care sector.
How about wound outcomes and amputations? I found most people thought that it improved wound healing, but a large number thought that it would reduce the rate of amputation. And Chuck, you mentioned that you're in a limb preservation center. Would you agree with this statement?
Absolutely, Tom. And again, I go back to that proactive versus reactive treatment. With the ability to look at those wounds and identify bacteria at 10 to the 4th before it becomes clinically evident, and do the appropriate debridement or appropriate dressings, then you stop the progression of that infection. And I think stopping that progression, avoiding the significant foot infection. When we look at our amputations in a limb preservation initiative, we know the etiology of diabetic foot ulcers, but the 2 factors that take a diabetic foot ulcer to amputation are, number 1, vascular insufficiency that can't be treated, but number 2, infection. So if all of a sudden you have that diabetic foot ulcer that becomes infected, that can be the trigger that then leads to amputation. With the early detection and treatment of bacteria, we prevent that, and I truly believe that we're seeing a decrease in the amputation rate because of that.
And Alicia, you're also vascular surgery, and you have many wound clinics. I'll just ask for you to give your opinion as well.
I agree with Chuck completely. I also agree with the statistics that, we're finding that, fluorescent imaging has led to not only improved wound healing, but better outcomes for patients and reduction in amputations, especially in patients with diabetic foot ulcers. If you can scan the foot and appreciate whether there's an underlying infection, this can lead to early intervention and better outcomes.
Dr. Serena, one of the unintentional consequences, or consequence is probably a funny word, but we've actually seen an increase in compliance with our residents or patients in the long-term care sector. They enjoy looking at the images on MolecuLight, and sometimes it's that encouragement that we need to have our patient allow us to sharp debride this week or be compliant with our treatments, our dressing changes, and our regimen. They look forward to seeing those images and how the wound's progressing and whether or not it's fluorescing this week.
Good point.
That's a great point. Also, we know that bacterial loads are detrimental to healing, but we can't see bacteria. So with the MolecuLight now, we can see higher bacterial loads, and we can remove them to help improve the outcome. And help to control the risk of additional problems, such as what I found in between the toes on that diabetic patient.
So the key takeaways for implementing the MolecuLight, bacterial loads are, bacteria are bad, and we need to address that as part of a good wound healing. Most of the guidelines, and I think the panel will agree, are out of date and don't reflect this current advanced technology. Clinical diagnosis is important, as Chuck mentioned, but it's not to be used alone.
On our side, we know clinical diagnosis alone simply isn't effective. We have immediate objective assessments through the use of MolecuLight. Looking at that bacterial burden, it enables us through this point of care imaging. The photos that I showed earlier, we know that person had diabetes, so their microvascular blood flow is impaired. They also had arterial disease, so their macrovascular blood flow is impaired, and the clinician was hesitant to debride. Through the use of MolecuLight, it gave them that added push to remove the unhealthy tissue and the bacteria that was in the wound bed. So establishing these guidelines really helped standardize the use of technology across the care providers.
And then finally, fluorescence imaging enables early identification and proactive wound care. And this will enhance healing and it's point of care. You're not waiting for cultures to come back. And I think this is the main points that the consensus panel, the authors who are on this call, want you to take away from this presentation.
Yeah, I think one of the key takeaways is the ability to be proactive. I think this is important in every aspect of medicine. If we wait for disease to totally manifest itself, many times we've missed the opportunity for a total cure. And the ability now in wound care to identify bacteria before you can see the changes from a clinical perspective, so that allows us then to be very proactive in the type of treatment that will address that bacterial burden early before it progresses to a more serious infection. I think a key point is proactive versus reactive.
Thank you very much for joining us for this webinar. Before we transition into the Q&A portion, I would like to pose a polling question for our audience. A question that's very important to the members of this team. The question is, do you have an antimicrobial stewardship program in place at your facility?
Thank you so much, Jennifer, and thank you to everyone on the panel for this great discussion. Now, while you're responding to the poll, we'd like to also invite you to submit your questions to us. clinicians?
Well, fortunately, there is excellent reimbursement on the facility side. This is federal, and that has been well established now. And I will tell you that we are billing on the facility side and receiving reimbursement. Similarly, this has gone before the AMA panel. It has a physician code. It does vary across the country on physician payment, but we're getting paid on the physician side as well, as we should. And I would encourage you to use something that's clinically efficacious and yet financially it's good for the clinic as well. We don't get that very often. It's very nice to have that.
Dr. Serena. Now, Dr. Rapallo, here's an interesting question for you. So if after debridement in an image that suggests no bacteria, I assume we would have to be concerned with developing biofilm and the need for appropriate dressings to decrease biofilm. Can you please comment on this?
Yes, that's correct. When I debride the wounds, I also take a MolecuLight image post-debridement to ensure that there is not heavy bioburden still on the wound before I place any kind of advanced modality or dressing management. So it is really a point of care determination on how I dress the wounds and manage them.
And I am looking, I see we have our poll results coming in, so let's take a look at that. Now, Dr. Serena, we're going to have those display on the screen here in a moment. What do you think of those numbers? So we've got 42.6% saying yes to our question here. Do you have an antimicrobial stewardship program in place? 35.2% saying no, and 22.2% saying I don't know.
Well, I would applaud the programs that have gone ahead and instituted an antimicrobial stewardship program. And I will tell you that if you go onto the Joint Commission's website, you will find the 5 elements that are essential for instituting a program. One of the things we've done is incorporated these guidelines that you heard on this presentation into our antimicrobial stewardship program. If you're in the other 2 categories, no, you don't have one or you're not sure, then I think you should go ahead and look at the Joint Commission elements of that are required. If you're DNV or your Joint Commission, I think at some point in the near future, they're going to ask to see that you've met all 5 elements of an antimicrobial stewardship program.
Great. Now, let's get back into questions here. Thank you so much, Dr. Serena, for your comments on the results. Now, Martha, here's an interesting question for you. How long would it take to implement the MolecuLight procedure in my clinic?
Yeah, that's a great question. For us being mobile, we're spread out into multiple states. So what we did was we got with MolecuLight, got a training scheduled for the Kansas City area because that's where I am locally. Once we were able to take the training and the follow-up test, then we were able to do interactive training so that we could get real-time feedback from the MolecuLight crew to ensure that we were interpreting the images correctly. And so with a dedicated team, that entire process took under a week. So within a week's time, we were using this device real-time in the field. And once that went off without a hitch, we were able to integrate it into multiple states very, very quickly. I will say MolecuLight's very used to doing this, and so they kind of took the reins and showed us how to do it, showed us how to get scheduled, but under a week was all it took, even in multiple states.
Amazing. Thank you so much. Here's a question for you, Dr. Anderson. This audience member writes, I understand you need darkness to perform the fluorescence imaging, but if I can't turn off the lights in my clinic, can you still use the MolecuLight?
You can use the MolecuLight. So there's a special drape that comes with the device that allows you to create darkness by using that drape with the machine. So, for example, we use it for our inpatients where it's very difficult to darken the room, and that works very well.
Great. Thank you so much, Dr. Anderson. Now, before our next question, we have another quick poll for those of you in the audience, which should display on your screen here momentarily, and this is to help us find out how many have joined us for today's session. The question is, how many people in addition to yourself are watching the webinar with you today? Now, if you are attending this webinar by yourself, simply enter a 0, and if you're in an in-service setting, an estimate is fine. We thank you in advance for your response. All right. Now, Dr. Apollo, I'm seeing this question in the queue here. Can the MolecuLight integrate with EMR systems? What's been your experience?
Yes, it can. There's a variety of EMR systems that are currently available for the MolecuLight use.
Great to know. Dr. Seminar, I see we have an interesting question here for you. Now, you mentioned the MolecuLight is ideal as signs and symptoms are not prevalent in wounds in the stages of pathogenesis. Would you say that this state is another stage of the wound infection continuum? And would it be the stages of colonization and overt local infection? Have you published this? And if so, can you please provide a reference?
The best publication that goes over the sensitivity of clinical signs and symptoms in diagnosing bacteria at a level greater than 10 to the fourth, which is the level at which bacteria impede wound healing, is the FLAG publication, and you can easily find it online. It was published in Diagnostics, I believe, in October, early November. And if you can't find it, send me an email, and we will send it to you since it was an online publication. What we found there is that the sensitivity of clinical signs and symptoms was very poor, 15 to 20%. And that was compared directly to quantitative tissue culture biopsies. So really the gold standard study performed looking specifically at clinical signs and symptoms.
Great information. Thank you, Dr. Serena. I'd like to hear from a number of members of the panel today on this next question. Now, given it is portable imaging, can you comment further on care settings where this can be used? Have any of you used this in surgical settings? Let's start with you, Dr. Orapollo.
Thank you. Yes, I have used it in surgical settings pre and post-operatively. It can be scanned pre-procedurally just to determine bacterial load on the skin surface. This obviously has the potential of possibly reducing surgical site infections. Although not published, it does have that potential.
Great. Martha, could you speak to this question as well? So given portable imaging, can you comment further on the settings where this has been used in your experience?
Yeah, absolutely. We have used it across 12 different place of service codes. So everything from group home, residential care, assisted living, skilled nursing facilities, long-term care, long-term acute care hospitals, inpatient acute. I would say the only care setting that we haven't attempted yet is the OR, simply because we're not surgeons. Although I'm not sure why it couldn't be used in the OR, since it's a non-invasive device that is used just for imaging. So we've had great success, and it's 100% painless. It fits in the pocket of the lab coat. You're not toting around 50 pounds of equipment. So what I would say is, wherever you're currently practicing, go for it.
Great. And Jennifer, let's hear from you on this question. We've lost Jennifer on the line here. Okay, let's move on to the next question here. Now, Dr. Anderson, do you know if MolecuLight is being utilized within the VA systems yet? And if so, what facilities?
So I work in a federal facility, a military medical center. I'm not sure how many VA hospitals are using the device. I'm uncertain on that.
Some more information after the program to the person who asked that question. Now, here's another interesting question. Is there any contraindication for use in pediatric patients? Dr. Serena, maybe you can field this one for us.
I can't think of a contraindication in virtually any patient. It's an image, it's a fluorescent image. It's not ultraviolet, it's just violet light. So if you can be exposed to violet light, then you can have this image performed.
And another one for you, Dr. Serena. What bacterial species does MolecuLight detect?
So in laboratory tests, it was able to detect most of the bacterial species that are present in chronic wounds. And I don't know what the exact count is up to now, but at one point we had over 30 or 40 bacterial species that could be detected. It detects pretty much any bacteria that has a porphyrin or pyrovaridine. Those are hemoglobin-like molecules within the cells. There are a couple of bacteria that don't fluoresce very well, Enterococcus fecalis and some of the streps, but they generally occur along with other bacterial species. So we have not found a problem with having bacteria present that can't be detected.
Okay, excellent. Thank you so much, Dr. Serena. Now, here's another question for members of the panel. Really good question here. Do you still perform cultures on the wound using the MolecuLight device? So let's start with you, Martha.
Sure, thank you for the question. So what we do is very similar to what Dr. Orapollo, Dr. Serena, and Jenny discussed throughout the presentation, is we're fluorescing and then doing debridement of areas that fluoresce, and then we're re-imaging again. If it's still fluorescing, we may try to remove it through sharp debridement. Once we try that again and we fluoresce again, if it's still there, we will do a tissue culture of the area that's fluorescing. Although I will say it has reduced our desire to take tissue cultures by about 80% of the time, because obviously if the wound is not fluorescing after debridement, there's no bacteria in the wound, so tissue cultures would not be medically necessary or even warranted to take at that point, unless if clinical signs and symptoms are present for potential for infection, because MolecuLight's 95% accurate, and so that's kind of our answer. We do when it's warranted, but honestly, it hasn't been warranted more than 80% of the time.
Interesting. And Jenny, are you back on the line?
Yeah. Sorry, I was on mute when I tried to answer the other question. Yes, and I think that I just want to highlight what Martha said, is that it guides the location of the culture. If there is still a glow after the debridement, sometimes you don't know where to collect the culture, and we don't want to swab a whole wound. So the MolecuLight can guide where the best place is to collect a sample for culture.
Great. Okay. We have time for a couple more questions. I see we're rounding the top of the hour here. Dr. Rapallo, if you are able to remove all the bacterial burden with adequate debridement, do you proceed with CTP placement?
Yes. The MolecuLight gives you the advantage of not just clinically thinking that you might have rid the surface of bacteria before CTP placement, but it actually demonstrates it visually, so you can appreciate the no evidence of bacteria before you place the cellular tissue-based product. And I do that in my clinical practice.
Apollo. And Martha, we've got another question here. What CPT code do you use when billing MolecuLight?
Yeah, I appreciate that. The codes that we're currently billing for are 0598 T like Tom for one wound location, and then each additional wound location would be 0599 T like Tom. And then there's some other codes, E1399, for example, for equipment code, and I believe there's a code for the dark drape that starts with an A code. Those may not be reimbursed by the payers, and so of course every MAC may be different, every payer may be different, so you'll want to kind of reach out to your insurance companies to see which codes they prefer that you bill.
Okay, and Martha, with that, can you bill for multiple images on the wound?
Yes. So if I'm, let's say that I'm fluorescing the left foot and there's 3 wounds on the left foot, that's one body location. So we would bill a 0598 T like Tom, but we would bill 3 units of the 0598 T. And then perhaps they also have 2 wounds on the right foot. So I would add a 0599 T code and bill 2 units of that 0599 T, if that makes sense.
Okay, Great. No, thank you so much. And I see that we're at the top of the hour now. For those in the audience who have questions that have gone unanswered today, a MolecuLight representative will follow up with you after the program. Additionally, you can contact MolecuLight directly by submitting an email using the Contact Us application found in the bottom tray of your console. You may also indicate your interest in learning more about the MolecuLight procedure by participating in our brief exit survey. As a reminder, we have included a link to additional topic resources available under the resource document icon, so please be sure to review these resources at your convenience. This webinar has been recorded and will be made available in full on demand, so please look for our follow-up email that will alert you to the on-demand status so that you can review any material that you missed or simply to go over the program again. So you will be redirected momentarily to that brief survey I mentioned, and we appreciate your participation in this questionnaire as you leave today's program. I would like to extend a very warm thank you to MolecuLight for sponsoring today's webinar. On behalf of today's guest panelists, as well as the teams at WoundSource and MolecuLight, thank you for joining us and for taking the time to view this program. My name is Miranda Henry from WoundSource. Have a wonderful rest of the day.